So welcome everyone to our forum. Hope you got the humor with the title of it. You're in luck. We're going to be talking about urological health today. And yeah, I've been in a wheelchair. My car accident was in 1982. So it's really weird to say anything was 41 years ago. But yeah, it was just this past June. And I have had my share of urological problems. People think that, not walking and being in a wheelchair is the toughest thing that we go through, but it really is a lot of the secondary stuff, isn't it, that can be a problem for us. And UTIs, kidney infections, kidney stones, all those fun kind of things that we go through as paralysis survivors. This is just one of the things we have to deal with. So just to read a quick disclaimer, which we're going to start doing, is that DAC WA forums are non-professional by nature, meant for sharing of mutual aid between its participants. The opinions expressed in meetings are strictly those of the person or persons who give them. Participants are advised to take what they like and leave the rest, and consult with their medical professionals before taking suggested actions. So just know that, yeah, we have some professional people on here, but we give a lot of personal opinions, best practices, things that just work for us. So just please keep that in mind, that these are, this is not meant to be medical advice. That should only come from your doctor. So, okay, well, I'm going to turn it over to Marty Whitman, who's going to introduce our main speaker for the evening.
Thanks, Elaine. Excellent introduction and very important disclaimer there. So I came off the streets to introduce our speaker today, and her name is Dr. Amy. Amy is a registered nurse, as well as she has her doctorate in nursing. Amy is an advanced practice nurse who is currently working as a clinical consultant within the industry of continence care. She has worked for Coloplast, the corporation, for 7 years in this role. While at Coloplast Corporation, Amy has developed and presented numerous successful education programs specifically for bowel and bladder management. She brings with her an extensive background in continence care for people with neurogenic bowel and bladders, both clinically and within the research realm for the past 17 years. Amy cared for people with acute spinal cord injuries at a model system rehabilitation center for over 13 years. As a clinical researcher, Amy has conducted numerous studies on clinical outcomes focusing on neurogenic bowel and bladder and quality of life after SCI. Amy's passion for maximizing outcomes, improving quality of life, and maximizing independence for individuals living with neurogenic and non-neurogenic bowel and bladders enables her to provide training and education to clinicians and patients within many different clinical settings impacted by these disorders. So, welcome, Dr. Amy. We're happy to have you, and we're excited to take in all that you have to give us.
Thank you, Marty. It always feels weird to have you reading about me when I'm sitting right here, but thank you for that introduction. I did want to say that Marty and I discussed that we are going to do bowel tonight, so I hope that's okay. I can come back and do more of a neurogenic bladder, but I know you guys, it's your last call, had some bowel management. Is that correct, Marty?
Yes.
So this is kind of a continuation of that, because we're going to talk about some different innovation that's out there for bowel. And I want you guys to know that this is completely open. I wish I could see you. I like it better when I can see you, but I understand the bandwidth issue. So I do have some slides. Okay. So I have been a spinal cord injury nurse for almost 20 years now, maybe even more than that. And I know that the biggest thing that you guys face, that I hear when I'm working with you out in the field, is bowel management. When we are able to fix a lot of things with bladder, there's been a lot of different things that have come out with bladder, but bowel technology has not kept up until recently. So that's what we're going to kind of talk about today. So basically what this one is, you guys, is this is how your bowels act. So if you guys look at this neurogenic bowel, no matter where your level of injury is, your bowels are affected. Because if you look here, I know you can't see my arrow, but if you look at that brain with the spinal cord, and you can see that in the sacral region is where the bowel and bladder lies. So any place where your injury was, at and below the sacrum is going to affect your bowels. So you can see here that almost every injury ends up impacting your bowel and bladder. Okay, that's why probably everybody on this call would probably chime in and say, hey, yeah, I'm having to deal with this because of where it lies. You can see here that there's different nerves coming out that control your sphincters, and then there's different nerves that come out that control your actual colon. So what happens is you guys' colon still works. It's still intact. It's intrinsic. Okay, so that's why your stool still moves across. You still form stool. Everything still goes across, but what you have a problem with is opening it up. So we're going to look here at the rectum itself right here. So you can see here, this is what I want you guys to see is if you look at the very bottom there, you can see the two, it's a very small honk. You can see that one of them's tightly shut and one of them's wide open. So if you have an upper motor neuron injury, so if you have an injury that's higher than T6, what happens is those sphincters stay tight, okay? They stay shut on you. When your bowels fill and your message goes up to your brain that, hey, you need to evacuate your stool, your body is not able to release that. So those sphincters stay tight. And you can see here, this would be somebody with tight. When you've got a lower motor neuron or you've got an injury that's in that lower region, the reason why bowel is such a big deal for you guys is because that sphincter stays wide open. So if you guys can see in the picture down here at the bottom, it's wide open, and I'm sorry, you can't see that very well. But what happens is if you just kind of imagine it like a rubber band, so the upper motor neurons, so those of you guys with higher level injuries, your rectum stay tight. The lower motor neurons, your rectum stay wide open. It's actually, in my opinion, a lot harder to manage those wide open ones. So if you're a para, especially a lower level para, you might really, really struggle with bowel control because you cannot keep stool in because your rectum, those sphincters have no control, they're flaccid. Okay, so when you look at what happens with neurogenic bowel, that's why all of these things happen. So when you look, and this is where I feel like we're failing you guys as a healthcare professional and as a manufacturer, 80% of people with spinal cord injuries say that their bowels are not in good control. So when we go out and we talk to patients, we do a lot of surveys. If you guys get a Coloplast survey, we're trying to figure out what you need and what products we can manufacture to help meet that need. 80% is way too big for me. I've been doing this for a long time, and it breaks my heart that we're still that high, because bowels have a direct impact on quality of life. As you guys know, they have a direct impact on whether you guys are able to go back to work, everything from your personal life to being able to go out and about. There's a lot of people that I meet that when they're younger and they get hurt, their bowels are in great control. And then all of a sudden they've aged with their injury for 20 years, and now all of a sudden their bowels are not in control. I want you guys to know and hear that you don't have to suffer. Okay, there are options out there, finally, to help. So we're going to talk about that. We have done some research too that shows, and you guys can tell me whether you agree or not, that if you had to pick one thing to get back from your injury, most people would pick sex first, then bowels. If we take out sexuality, bowel would be the first thing. So would you guys all agree that bowels are pretty significant?
Yes.
Yes.
So that, to me, we need to fix that. So when I go out there and I'm talking to clinicians, I am pushing them to talk to you guys about this. Be open to your clinicians, because I've done a lot of work up in your area on the clinical side, so they know about Peristeen. But here, let's teach you guys what Peristeen is real quick. So when we're looking at the basics of a bowel management program, this goes back to the basics of what you guys learned when you were in rehab. We want something that's effective. We want to get that stool out, right? What we're learning is that even lower motor neuron patients, so even those of you with lower level injuries, we're getting you way too constipated. So to control your bowel movements, we're tending to rely on constipation, which is not a good thing. We've learned that's not good. We need to get your bowels clean. We need to get things moving. As you guys age with injury, you tend to start doing things that work for you. And a lot of times it equals constipation. So I want you guys to talk to me tonight. I'm going to leave some time, quite a bit of time actually, for you guys to talk to me about what you're seeing and kind of some different options for each of you. But we also want it to be predictable. Okay. So Marty's the only one I know, so I'm going to pick on him a little bit. I don't really know him, but I want Marty to be able to say, okay, I have a date tonight. I'm going out to a concert. I don't want to have to worry about my bowels. Okay. I want him to be able to go out and do whatever he wants and know that his bowels are going to be in control until he starts taking it over again the next day or the day before. because we've maximized how much we get out. So when you guys look at the colon, see how the colon here looks like an upside down U? So the top part, the part that goes up here is called your ascending colon. I don't care about that. None of us can see that, feel that, whatever. It needs to feel, okay? That's gonna be how our stool starts forming. Then it goes across the top. That's called your transverse colon. Okay, that's when it starts to become like we maybe need to evacuate it. Then you go down the lower part on this left-hand side here, and that's your descending colon and your rectum, okay? That's what I want to get out. So when I'm talking to you guys about cleaning out your colon, that's what I want to clean out, is that entire left side of your colon, because then we can get you cleaned out. So can you imagine? I would love to get that much stool cleaned out of myself, but that's not where I'm at. So that's our goal, okay? You guys are managing bowel and bladder, right? So you don't drink as much as you probably need to, because you don't want to lose, you have to IC more, right? And so you have this delicate balance, but to manage a lot of your symptoms, the medicines you guys are on are dehydrating. But my point is, it's not probably where it needs to be. We can all probably do better there, but there's lots of reasons why you guys limit your diet. My guess is you guys aren't quite as active as you were when you first got injured. And what I want to encourage is find ways to keep that activity going, because our bowels rely on that. So many other things do too, especially you women on the call. We've got to be in our standing frames and doing things that we did before because of different hormonal issues that women go through, but that's not what this talk is about. But to keep our bowels moving, if you guys get upright and get moving and get that bowel moving, it can only help everything else we're trying to do, okay? And then we've got medications. So some of you, it may help to add a stool softener. Do not be afraid of stool softeners. All they do is bring water into the bowel to move it. All of us clinicians in the field are still using Miralax safely and effectively. It's a very great med that we use very often. Okay, so then there's the digital rectal. When I do this, only in this group would you guys know what this meant, right? That is still going to be something that we need to look at for the upper motor neuron. So if you have a higher level of injury, when I start to talk about Peristeen and irrigating your bowel, you're going to still need to do some dig stem, because otherwise your body will hang on to that water. On to Peristeen. So Peristeen is a transanal irrigation system. Okay, so what it does is it basically helps get us cleaned out. So remember when I showed you guys that colon and I said I want to get that whole descending colon and the rectal vault cleaned out? I guarantee you most of you right now are only getting your rectal vault cleaned out. Unless you have started Peristeen or unless I have talked to you, you probably aren't doing anything more than that. That's what the enemies does. That's what dig stem does. It gets that bottom part of the rectum cleaned out, which is right here. Our colon, I can get you cleaned out, your whole descending colon cleaned out with just water. And that's what Peristeen does. So it helps with constipation, incontinence, but the biggest thing for me is it gives you back time. As you guys age and I start working with you as you age, and I start hearing that you're spending 3 hours on your bowel program, or maybe you're even spending 2 hours twice a day, that's ridiculous. We can get you less than an hour. That's my goal for anybody with a spinal cord injury. I don't care what level you are or what we're doing. We should be able to get your bowel program done in an hour. And then your quality of life. So again, as we're all getting older, I'm aging too. There's things that we're all having to deal with. I want to make sure that your bowel and bladder needs meet that as you guys age with your injuries. And if there's people on here that are younger and you've just been recently hurt, I want to make sure that we're instilling things now so that as you age and as you age with your injury, these things don't become a problem for you. So that's the goal of Peristeen. And you can see here, again, just back to the whole quality of life thing. There are studies that show that Peristeen does have this impact. We are able to improve quality of life and do all of that stuff, which is why insurance companies are covering it now, which we're super excited about. So this is what Peristeen looks like. It's a bag of water. So if you're not going to drink the water, you wouldn't want to put that water in Peristeen, because your rectum and your bowels will soak up whatever you put in there. So, but otherwise, if you're someplace, just a regular place, or your home, you're not traveling, tap water is fine. So it's just warm tap water that fills this bag. This bag holds about 1,500 cc's. So I'm going to tell you guys a number and I don't want you to panic. If I were to train most of you right now, I would probably want 750 to 1,000 cc's of water. That sounds like a lot, but our colons can hold a lot. In order for me to get that stool out, I would need bigger volumes of water. So you can see that this holds a lot of water. And then I want to show you guys this catheter up close here. So this catheter right here, do you see how it's got a balloon on the end? What the catheter does is you put the catheter in and it's about the length of your finger. When you do dig stem, you're going right here because you're trying to stimulate those sphincters. So if you remember that picture, how the sphincters come down at the bottom and they form this kind of seal on your rectum so the stool doesn't come out. We want to actually bypass those because they're not behaving. They're not doing what we want them to do. We're going to go past both of those sphincters. We're going to go into the rectal vault, which is where the stool sits, and blow up the balloon there. So we're going to blow up the balloon, and that keeps the catheter in. By doing that, we are able to, I have a picture of that here in a second. By doing that, we're able to instill water. So you can see here, this is just who's able to use it. I want to get to the picture here real quick since we're talking about it. And then we'll go back. So do you see there how it sits it sits in that rectum, in the rectum, and then the water goes all the way up. So if you imagine 750 to 1,000 cc's of water, somebody like Marty, I might even go up to you to 1,000, maybe even 750 doses, because I want to get that bowel stimulated and moving. Okay, it does not hurt. It doesn't hurt your body. It does not cause hyperreflexia. It just simply fills the colon so that you guys can evacuate your stool. It's meant to be used every day or every other day. I've been doing this for 9 years, but what I've learned in those 9 years is that the more water for you guys, the better. It's really hard for you to intake enough hydration for your bowels because of the meds, because of your IC, because of all these other things that you guys are worrying about. And so most patients actually do Peristeen every day. They find that it's super easy to do. They can keep their independence, or if their caregiver is doing it, their caregivers love this because it's so easy, but it can be done every other day. Some patients like to do it. Most patients that I see like to do it every day. So you guys can see the catheter here at the bottom. It's got those ridges. This is meant for you guys to do independently. C5 and lower, I can absolutely get you independent. It's a matter of using your tenodesis so that we can get it in. If you are higher than that and independence is not, that level of independence isn't your goal, but independence of teaching your caregiver how to do it or managing your bowels verbally, this is very easy for a caregiver to understand your verbs and how to use it, and you can direct your care based on how much water, and that's where you can gain your independence, which I love. You can talk about, hey, what results did I get? Ask what results you got, and then you can help manage that water that your caregiver puts in. So it's pretty cool. You guys can have independence with that. This is a picture of what it kind of looks like as it goes in. So do you guys see how there's our upside down U again? And you can see how the catheter is going in the bottom. You can see the balloon there in the rectal vault. And now you can see the stool moving. The reason why I asked you guys about stool softeners is that if any of you were to want to start this, the first thing I would do is start you on a bowel. I would tell your doctors to start on some sort of a stool softener. The reason for that is Peristeen cannot get rock hard stool out. It cannot get hard stool out. That's why a stool softener or Miralax, something that you guys can use to help get that stool soft so Peristeen could get it out, would be cursory. If you guys look at Peristeen or want to talk about Peristeen and your doctor suggests something, please listen to them. In the past, you guys may have had really bad experiences. I get it. I've tried to help people through that. What we're doing now, though, is we're softening the stool and then using Peristeen to get it out. So trust that we're going to soften your stool, which is scary, and I totally understand. But we are going to get it out with Peristeen, which we weren't doing before. Okay, so kind of listen to your physicians if you guys decide to move forward with this, any of you. And that's
Amy.
Yeah.
A couple questions came up. I don't know if you saw the questions.
I cannot see them.
Okay, from Curtis, he asked, can this be used with a colostomy?
You to irrigate your colostomy? No. So okay. There is a cone attachment though that I can share with you that Coloplast does make to irrigate the colostomies.
Second question by Rob was, what's TAI stand for?
Transanal irrigation. Sorry. So okay. Transanal means we're going to go up and over. All right. So next, this is a fancy picture. So this is somebody with a spinal cord injury. You guys, I only want you to pay attention to those last two pictures there. The top right and the bottom right. The top right, again, this is a real colon, so it kind of looks more realistic this is somebody with a spinal cord injury. My guess, I don't know how many are on this call, 98% of you would probably be this backed up. Maybe not, maybe a little more of that rectal vault opened up. But most of us walk around this full for different reasons. So then you come down here and you see how this entire bottom half, this entire bottom, that descending colon part that I keep talking about is clean. What they did with that is they did that with water. All of you guys have different level of injuries. Just kind of throw out some things that you guys think would be better if we could get your colon that cleaned out. UTIs is one. I can tell you clinically as a nurse, UTIs is one. What else do you guys think would
Probably have
happen
more
if you-
energy.
Yeah, because you feel better, right? Yep.
Is there any correlation between a full colon and developing polyps?
Yes, huge. And hemorrhoids and all kinds. That's I wish I could see you guys. That's a great point, you guys, because what he's saying is that increased pressure of that stool causes that pressure and everything kind of starts to pull out. So yes, this would decrease the risk for that. And if you have them already, it kind of shrinks them up. Rob, did you have a question since you came on? Or were you just saying hi?
I was saying hi, but I also have difficulty reaching back to my bottom. I'm interested in the device, but I'm wondering how I would be able to do it myself with independence.
How much, where's your injury, Rob?
I'm a C5, C6 incomplete.
Incomplete. So do you have any trunk control?
Yes, I do.
Okay. So what we would do is it would all come down to your commode chair. Do you have how long have you been hurt for a while?
I've been hurt about 3 years. I transferred
okay.
to my toilet, and I have a bidet.
Okay, so the first thing I would need you to do is get a commode chair, and this is where we could get you independent. Do you go to Harborview? Where do you go?
Swedish ARU. My doctors are out of Swedish.
Okay, I've actually trained some of them. So what a commode chair does for all of you guys, a commode chair, it's really, really hard to do Peristeen on the toilet, okay? I know a lot of you probably do your bowel programs on the toilet. What I need you to do, so if you imagine, and I'm sorry I don't have Peristeen with me, if you imagine having to reach behind you and put a catheter that's this big in your rectum. So if this is my rectum and I'm sitting on the toilet, I don't have any room to get that catheter in my rectum, right? So what I need is a commode chair with a side opening. And all the clinicians in Washington, Rob, I would have to probably talk to some of the Swedish docs, but the Harborviews, the UWs, some of those bigger rehab places, I've already talked to you about this. We need to get you a commode chair to be independent. So my point is, Rob, yes, you can be independent. Yes, we can teach you how to do it, but you would probably need a little, some equipment.
How long do you leave the catheter and balloon inflated before you can take it out and evacuate?
So the catheter, that's a great question. The catheter only stays in while you instill the water. So you would put the catheter in, you instill that 750 cc's of water, which takes about a minute or two, and then you release it. The reason why there's no dwell time, why you don't leave it in, is because our colon has these little receptors on it, or little buttons, that when they stretch, usually with stool, it starts moving, okay? So what the water does is it's tricking your colon and saying, hey, stretch and start moving. And then what you do then when you do your ditch stim, because Roland, I think by looking at you, you probably do ditch stim. Anyway, so you would put that water in and then immediately you would do your ditch stim. And what that ditch stim does is it says, open up, let that water out. And then your colon's already contracting. So it lets the water come out. Right. So the whole thing from start to finish takes anywhere from 30 to 45 minutes. Somebody like Balin, who is very incomplete and things would probably move a little bit faster for her, she might take 30 minutes. Whereas somebody like you, Roland, who's got a little bit higher level injury, it might take us 45 minutes to get you kind of cleaned out and do your ditch stim and all that kind of stuff. So gotcha. Colorectal is not a big target for us. We are trying to focus on the PM&R docs. But I know that once you guys get out of rehab, you're seeing these other specialists. So feel free to give them our contact information, Roland, mine, because I cover you guys. And just like Rob's going to give it to Swedish, and we can get some doctors looking at it. UW is already doing it. Harborview's doing it. So if you guys want to check in, or if you have connections over at Harborview or UW outpatient, they're all already doing it. So bladder, do you guys have questions on bladder, or what do you want me to talk about? Is there something specific? Marty, I can talk about bladders all day.
Okay, so the three things, transitioning to urology, I think the three things are: number one, intermittent catheterization; number two, superpubics or supertubes, whatever you want to call it; and number three, the probably rare, but sometimes Mitrofanoff. How you say that?
Mitrofanoff.
Yes.
They're not rare anymore, but yes.
Okay. So, and we do have, I believe, Sarah, I think, might be on this call, and she's going to speak on behalf of the M word.
Mitrofanoff.
Okay.
Yeah. So, okay. So let's talk about intermittent cath for a moment. So what do you find is maybe a good, as Elaine would put it, a good, what's the term you use?
Best practices?
Thank you, best practice. Thank you.
Am I
Maybe
answering?
best practices in terms of cathing?
Am I answering this or somebody else?
Yes, you.
Okay. Best practice. Let's see. Well, every 4 to 6 hours, not once or twice a day. The biggest thing for me, you guys, is that I want you to be out and about. What I don't like to hear is that I only cath in bed, or I skip caths when I'm out and about because I don't feel like I have the right product out there. You know, I don't want to use it out and about. So using it every 4 to 6 hours, and then keeping up on innovation. So I do work for Coloplast. I happen to know our products very well, so I know what innovation we have for both males and females, but there's other manufacturers out there. So pay attention to the innovation, you guys. We're all trying to keep up with what your needs are. What you started cathing with 10, 15 years ago is completely outdated. If you have not upgraded your catheters, you need to look into it. If you're not in a hydrophilic catheter, I'm going to tell y'all right now, every single one of you is going to fight me on this because I fight with men that have been hurt for a long time. Women tend to switch a little easier. If you're not on a hydrophilic catheter, it is the gold standard and the standard of care now. So let's talk about why.
I guess the question is, if it's not broke, why fix it? If a male is still doing well with lube and a silicone catheter, why make the change to hydrophilic?
Here's what I would challenge you on. I know clinically that what you're doing is not okay. I know that you're playing roulette with your urethra. And Monty, you and I, we already talked about this. I understand that what you started on is working, but we have better. And the reason why there's better, and the reason why hydrophilic catheters are now the gold standard of care, you guys, if you went into UW or you went into Harborview or you went into Rancho, any of those big Santa Clara Valley, you won't even find a tube and lube on those hospitals anymore. Okay. The reason why is because they know it's not healthy for your urethra. So while you're cathing now and doing just fine, we don't know what kind of damage you're doing in the future. And that's the problem. We don't want you to get these massive UTIs. Baylin, as we get older, we start to dry out. So even though our urethra is only 1.5 inches, these guys have to deal with 8 inches of urethra, which is way longer. We don't, as women, only have 1.5 inches we have to deal with, but that urethral tissue starts drying out very quickly as we age. So I want to keep that tissue intact and keep it protected. Okay, so for women, the reason why hydrophilics are so important is very different than for men. Men have 7.5 and 8 inches that they have to go from the outside of their penis into their bladder. You guys are cathing that 2,000 times a year. Okay, you're also pulling a catheter out. So Marty, I called you Monty. Marty, when you tell me that why, if it's not broken, why fix it? Because clinically, I can see what's happening and I can see the damage and I'm worried about you. That's why. And I know clinically that I would never start somebody now on a tube and lube. Why would I want you to keep doing that just because you were injured? Does that make sense?
Yes, good argument. And if hydrophilics were available 40 years ago, I probably would have started on those. Yeah,
but
and
they
never had a problem in the middle. But they weren't. And so now I'm glad that they are. So I guess that's a good argument.
Well,
to do it now. So,
it is I do want to say though, Marty, it's your body. So and I just had this conversation with a 35-year-old. He's in the hospital right now. So I talked to him about it. He's using a Roosh, such an old catheter. And I pointed out like all these things about him. And I said, but ultimately it's your decision. I just told you the clinical benefits. I told you what I'm worried about. It's your body. If you want to keep using the catheter that you trust and that you've been using for 35 years, Marty, that's your choice. I just am telling you what, I just have to teach you what's out there clinically, and then you guys can make that decision. So Baylin, same with you.
How do we get approved for this?
So reimbursement is something crazy. We could have a whole conversation just on that, you guys. There are there are 3 different types of catheters I want to teach you guys about. There's a straight tip catheter. There's a coude tip catheter, which has a little curve on it. And then there's the one that Baylin's talking about, which has a bag. Okay, so it's got the catheter and the bag. Each one has different things that you have to use to qualify for. All of you would qualify for a straight tip, okay, just by having a neurogenic bowel, okay? The coude tip is if you're having problems inserting a catheter, you would automatically qualify for a coude. So sometimes people don't think spinal cord injuries need coude. I'm trying to push that a lot because I think there's a new flexible tip out there that I think really helps men navigate that urethra. So the lube doesn't stay on your catheter, okay? What the studies have shown, and I actually have videos I can show you guys, of when you guys put the lube on the catheter, it actually stays on the outside. It doesn't go in, which is why, Bailyn, if you have sensation, or a lot of women are like, oh, I feel icky, like I feel gross, because all that lube stays in your vagina. Like it just doesn't go in. For men, you can see it kind of stay on the outside of their penis and it'll drop off. It doesn't go into that urethra. So you're basically putting in a dry catheter. So hydrophilic catheters, no matter which manufacturer you use, it's got a coating on it that when it mixes with water, it makes it nice and lubricious. So it stays on the catheter when you put it in and pull it out. So that's why people are going to the hydrophilic catheters, because you guys don't have to worry about that step. It's kind of done for you. It stayed on there. It stays on the catheter so that when you go in and you pull it out, there's not friction. We know that friction leads to UTIs and complications, especially with men in strictures and false passages and stuff. So, but Bailyn, when you're going from a non-coated catheter to a coated catheter, hydrophilic catheter, it's not, there's no cost change to you. So the whole reason why I said there's codes is, you notice I didn't say there was a hydrophilic code. So if your doctor writes for, let's just say it's ours, it doesn't have, I don't care as long as it's a hydrophilic catheter, but let's just say it's SpeedyCath because I know that one. And it's a straight tip catheter. You will pay the same amount for SpeedyCath as you do for your straight tip uncoated with gel. You actually pay more for that because you have to pay for the gel. With SpeedyCath, you won't have to pay for gel. So it's the same cost to you as long as you guys are within that same category. Okay. So if you go from a straight tip to a coude, it's going to cost you guys a little bit more because the coude catheters cost more.
It's all about coding. It's all about coding.
Yeah. But it's not, if you guys want a hydrophilic catheter and you hear the words, that's not covered, that's not right. Talk to Marty. It sounds like Marty knows the reimbursement world well.
Yes.
Connect with Marty and have him talk you through that, because you should not ever hear that. They don't get to decide what catheters are covered. They get to decide what code's covered. So if that particular dealer doesn't cover that, then there's probably another dealer out there that does.
Just be very specific when you're getting your prescription from your doctor that you're very specific on the exact catheter that you are required to use.
Marty, that's a great point. And right dispense is written.
So, but anyhow, let's move along to maybe really quick, like in terms of intermittent, a closed system versus an open system.
So I love the closed systems for you guys. When it comes to a bag system, Marty, the bag systems have, they're all enclosed. So they've got the catheter and then they've got a bag attached. Those are awesome when you guys are up and about. So I absolutely love those catheters. I'm actually working with a team at Medicare to get these covered for everybody with a spinal cord injury so that you, Bailyn, you don't have to have 2 UTIs. Anybody now with T3 or higher, we have gotten this, T3 and higher can automatically qualify for a bag system. So Bailyn, that would be you. Unfortunately, the lower level of injuries, Medicare is not buying into that yet, but we are still pushing for that hydrophilic, for that bag, for everybody to be able to get a 5-3 catheter if they have a spinal cord injury automatically. But Bailyn, you are absolutely right. There are specific things that you have to meet for Medicare to get a bag system. If you guys have a private insurance, they're much more likely to cover a bag system. Or if you're T3 or higher, UTI, more than 2 UTIs, if you happen to have, if you're on this call and you have MS, MS, there's the drug that you take that automatically puts you in that category as well.
So the closed system, obviously, obvious or not obvious, but closed meaning it's touchless, correct, Amy? Okay, so touchless meaning you're not touching anything, therefore you're going to minimize any type of contact and minimize therefore infection. So is that accurate in saying? But it does take a little bit more dexterity in your hands or your fingers to use a closed system, because there's some more things going on that you've got to hold on to. So is that fair to say, Amy?
Well, the one that we gave you, yes, that does require some hand function, but no, we do have a catheter. Rob, I looked right at you when I said this, and I am 100% behind this. I want you guys as independent as you can. So to have a product that you have to have good pinch for would not be standing behind that message. We have a catheter that you actually hold up here. Let's say this is your penis. You don't have to have good hand function. So I'm using good hand functions just to show you guys my urethra. But as long as you have tenodesis, I can get you cathing. So what you do is you hold the catheter up here. So if I just use my tenodesis to grab the catheter here, and then you hold it up here and you drop, and it's so slick and it's got a little bit of firmness to it that as it goes in, all I'm using is gravity and it gets into the bladder. So no, Marty, the product you use does require some hand function and learning how to use it, but there is one absolutely that you just drop. So if you see me going like this, that's because that's how I teach higher level quads how to just drop. But Bailyn, it's hard to see that, right? Like I understand, like I'd love to be able to actually show you guys the products if you want.
Yeah,
But there
I'd
is
love to
product
see
for
some.
limited hand function.
So let's move along to Superpubics and then the M thing.
So you just need to spell it out, Marty, and you'll be able to pronounce it.
I know, I'm not looking at it right now.
Written down. Yeah, it's
Yeah.
Yeah.
So Superpubics, I know there are some folks in the crowd who have them.
Mhm.
It's kind of ironic. Just the other day, a good friend of mine and happens to be a neighbor down the street, he has one. I know he's not on this call. When I think of Superpubics, I think of risk of infection because you've got the thing sitting in your bladder and it's just harboring infection all the time. But he said that he's had great success with it, and I think a lot of it has to do with his management of it. He changes it every 3 weeks, and then I think he said, if I'm not mistaken, every day he flushes it maybe, and that has worked well for him. But I've had other friends who've had Superpubics, and if you have a Superpubic and you want to say something about it on this call, please do. But they'd have to drink tons of water and just to keep that thing flushed all the time. So Amy, you want to say something about that? Maybe we have. Yeah.
Marty Rowland here. Can I interrupt you?
Go ahead, please.
Can we throw chronic Foley users in there too? Because
sure,
it's not
absolutely.
only SP tubes that
Yeah.
people are using. I'm chronic Foley catheter use.
Speak to us.
Was a condom cath user in the beginning for years and years and years. That worked great until my bladder decided it doesn't want to stretch out anymore and collapse and fully empty. Started getting a lot of bladder infections. My only option was to IC, which as a C5 quad was not doable for my lifestyle. And having a bladder neck surgery during my early years, I didn't have the option of an SP because I would drain through the bottom of my bladder. So the Foley is my only option and continues to be. Lots of infections in the beginning because you do have this foreign body in you. And I had a hard time for about 1.5 years. A lot of antibiotics, overtreated even before I had the Foley. I ended up with a resistant bug, a very resistant bug called Pseudomonas. And that's something now that I have to live with and manage, like you referred to. There's a product out there. It's not Coloplast, but it's called Poises, and it's a dual lumen catheter, where it has a balloon at the tip and a balloon at the anchor point. The tip balloon creates a buffer between the bladder wall and the catheter. And I found with that catheter, drinking copious amounts of water every day, because with a catheter in you, the solution to pollution is delusion, and it's working. That's my nutshell.
That's perfect. It works for you. So you're doing the regular indwelling catheter through your urethra. Okay, interesting. I honestly didn't think we would have anybody in the crowd with that, because unless they were a new injury, and unless it hadn't been decided yet what direction you would go to manage your bladder. But that's great. That's great information, and I'm glad you found something you're able to manage it. And are you now colonizing that bacteria within your bladder? Is that what's going on?
Yeah, it's pretty much ever present. When the viral load gets too high, then I start getting my symptoms of UTI.
Gotcha.
You know, sweaty, shaky, fever, all that. But it's with the foreign body in there and that bug being so resistant, it's just something I have to live with.
Right.
But symptoms are next to none if I'm doing the right things.
Gotcha. Yeah, absolutely. You got to stay on top of it. Great. Anybody else in the crowd who has a Superpubic that wants to chime in what they do to manage it, and that's successful or not successful?
Yeah, hey guys, it's Kenny here. Yeah, I'm a longtime Superpubic user. I got my spinal cord injury in 2004. I made the jump to Superpubic in 2007. I was experiencing some penile erosion, which can be a factor when you are having that indwelling catheter for a long time. It can kind of eat through the tissue of your penis, and so that was becoming a problem. And I was having a lot of UTIs as well. But I made the jump to Superpubic in 07. Yeah, like Roland battled UTIs still. And, went septic a few times. And now I figured out if I change my catheter every 2 weeks, and I've been using a silver coated catheter that's supposed to be a little bit more antimicrobial. Maybe some of the experts that are on here that know some of that equipment better may be able to speak to it. But Amy was right about the water. I drink 4.5 liters a day, and that keeps me pretty much infection free. I've had about one infection in the last 5 years, but drinking water is my full-time job. So, but it does make it easier to manage. It's really easy to change. And my wife knows how to do it. I've trained caregivers on changing it as well. So it's a very applicable, it's a very viable solution for me, but like everything, it just takes constant maintenance.
So Roland mentioned something about there's two balloons. One is at the tip to be like a barrier between your bladder wall and the tip of the catheter. Do you have that too, or do you just have a regular one?
I do not. And I know, we've got a few different experts on here that might be able to tell us whether it's Amy, or I think we've got a couple of.
Oh yes, there's a couple more, a couple Michaels.
Yeah, they might be able to speak to that. I know Michael from Shield and Michael from NuMotion are both on here, or were.
I'm Michael from Shield. Can you hear me?
Okay, look like Michael came on. I'll let him talk.
Hi, everybody. Michael from Shield, and we're a third-party billing company for home healthcare supplies and a whole catheter array, a crazy array of products available. So we could take calls from people individually and find out what they're using and find out what they're qualified for and find out what their allowable quantities are. And we could spend a lot of time on this. So I'd be happy to do one-offs.
Yeah, I'm here. Can you hear me?
Yes.
Okay. Yeah.
Yeah, maybe introduce yourself real quick and tell us how you might be able to help any of our members out.
Yeah, you bet. So I'm an account manager with NuMotion Medical Supply. Most of you might know NuMotion from the rehab side with the equipment, but we also have a medical supply division. So we don't promote any one brand. We offer all options for all brands and all types of catheters. We also do both all of the TAI products as well as incontinence products. So briefs, pull-ups, and those items too. And like what Michael said too, when I can be available for questions for any of the products. I do consultations and either bedside or on the phone or Zoom or whatever is most convenient.
Great, thank you.
Yeah.
Okay, let's move on to that interesting surgery that's done. And it sounds like there might be some, well, Amy said, well, it's not round anymore, but is Sarah on the line?
Yep, I'm here.
Okay, great. So Sarah,
Hi.
Hi. Hey, thanks for joining us. Hey, tell us about the surgery. I'm assuming it's a surgery, correct?
Yep. I got the Mitrofanoff. Gosh, it's probably been like 15 years. The best thing I've ever done. I wish I would have done it years ago before that. Never had any issues as far as infection. I do get UTIs maybe, I don't know, every couple months, but the UTI doesn't last very long. I pretty much drink a lot of water and drink some green tea and it goes away in a couple of days. I've never had a fever, never been hospitalized for UTI as long as I could remember. I've only been hospitalized once for UTI, and that was many, many years ago.
That's great. So Sarah, how long have you been injured?
Since 1994.
Okay, so you said you got the surgery about 15 years ago, correct?
I think so. Yes.
So how long, so was it around maybe 15 years that you didn't have it?
Yeah, I'm in my mid 50s now. So gosh, it could have been longer than 15 years. I can't keep track anymore.
Okay, but what was it like before you had the surgery that led up to considering the surgery and actually getting the surgery? So what led up to it?
Well, my quality of life was terrible. I was having accidents all the time. I had to cath every couple hours, and I would spend, half an hour sometimes in the restroom, mostly because I was wearing jeans, probably the worst thing to do, but I would spend a lot of my time undressing, and cathing was really difficult too. It just was hard for me. It was just terrible. And plus I was going to school and working. So it just wasn't working. And I met Dr. Gandhi. It was a blessing because he stopped taking adult patients shortly after he saw me. He helped me. Like I said, it was a gift from God. So I'm so happy that I have it. Yeah.
So it's worked out well for you. So first of all, let's maybe step back for a moment. Can you share with us what the surgery maybe entails in brief, maybe not in detail, but kind of the basics of the surgery?
Sure. So like if I was talking to a child, basically they use my appendix to route to the bladder. And originally I was supposed to cath through my belly button, but my appendix was too short and there was no way for them to know until they actually cut me open. But Dr. Gandhi did not tell me that if the appendix is too short, that they would have to put a hole in my abdomen. He never told me that. So when I woke up from the anesthesia, I looked down and I saw a hole down in my abdomen. I was like, WTF, I was really upset by that because it was awful. There's this hole and it was very abrasive. And so I waited for Dr. Gandhi to come see me and he explained to me what happened. And so it's not like, okay, your penis is too short, we're not going to do the surgery because Sarah's not going to wanting to cath down there. There was no option. So he had to do it that way. And I was fine with it. I don't like having the hole down there because you can't see it, but it's better than having to cath every couple hours.
So you got over that rather quickly.
Yes.
Okay.
Yes.
Yeah. So is there do you leak at all?
I don't really leak up there, but I still do leak down there. I've had surgeries. I had the bladder sling. I was seeing Dr. Miller. But yeah, like I was saying, I've always had leakage problem. So I still do leak. And that's why the Mitrofanoff has been a blessing because I don't have to self-cath. I could just pee in a bottle. And I could get really lazy because I could just do it in bed. I could do it, sitting in my chair. It's just the convenience is just wonderful.
So you do catheterize though, don't you? Just through a different hole?
Yeah, it's just through my abdomen.
Okay.
Yeah.
So is there like a flap that opens and closes? Do you push a flap open and then how does that work?
There's no flap. It's just basically a hole.
Yeah, but something's got to close off so you don't leak through that passage they made, correct?
No, it's if you think about it, it doesn't make sense. You would think that things would leak out, but the passage is so long. If you think about it, the appendix, I don't know, it's probably 8 inches. So unless my bladder is completely full, but if it does leak, it would leak down there. It's only leaked a couple times up here. And I think that was because the way I was laying down on the bed. But that was many years ago and it hasn't done that yet. So
Do you catheterize on a rigid schedule? I don't know, rigid is the right word, but every 3 hours, every 4 hours, or do you know when you have to go and then you catheterize?
You know, to be honest, I do it often because I don't want to leak. So every couple hours.
I see. Okay.
Mhm.
And it's obviously not a hassle, and that's a good thing.
Yeah, it's easy. But
It-
since the catheter is a 10 French, it does take me a long time to empty.
Oh, yes, that's right. It's a very small catheter. That's
Yes.
right.
I could probably use a bigger one, but I think it would hurt because when I do put a catheter in, it does sting a little bit. So I am doing this, and I'm sure Amy probably won't like it, but I do keep the catheter inside me on a daily basis, and I change it out once a day. And what I do is I keep the catheter in, and it's the long one, and I put a cap on it in the end. That way I'm not constantly just shoving one into my hole every 2 hours, because that would just be very abrasive.
Now that's interesting. I thought you were intermittent cathing, which
No.
is you put in, you pull out. That's interesting. So you plug it,
Yes.
you keep it in for a day, and then you plug it, and then you drain it. Wow. So Amy, go ahead.
So Sarah, I love that works for you. You know what I'm going to say. That is not medically what we would ever suggest to somebody. But Sarah, cool, great for you. Mitrofanoffs are meant to still catheterize every 4 to 6 hours or whatever. Sarah, what I would wonder is a different catheter for you. There's so many different options, and especially if you aren't using a hydrophilic, all those same things that I just talked about are just as important for Mitrofanoffs. Mitrofanoffs are becoming extremely popular. I would say 90% of females that are newly injured are getting them. They're making them wait a year just because they want to see what kind of bladder function they get back. But Sarah, it is life-changing for patients. And I'm sorry yours wasn't able to go through your belly button. That is the best to go through there. But if you start getting sick or leaving that catheter in starts to become a problem for you, there's other options that you can look at for catheterizing that stoma that won't hurt, that we can kind of talk about, because it's just a breeding ground for bacteria. And I'm scared you're going to get sick.
Okay.
But everybody else that's on the call, that isn't how clinically Sarah was taught, right? How to use her Mitrofanoff. But it's just a catheterizable stoma. So basically they created a urethra for Sarah that goes up. So instead of for females having to try to find our urethra in all that dark, crazy area while you're sitting in a chair, now you guys can catheterize from up top where you can see. So it's life-changing for women. And I'm super happy that you got it, Sarah. But for everybody else out there, when you guys are talking to newer injuries, it is still a catheterizable stoma, and very popular with the spina bifida kids. You'll see a lot of kids getting this surgery. If you know anybody with spina bifida, a lot of those kiddos have it too.
You know,
Great.
I remember Tammy Wilbur. I think she'll be okay if I mention this. She has a Mitrofanoff, and I do remember her hole is not in her belly button. Hers is on her abdomen. And I was really surprised that you couldn't even see her hole. I was like, oh my God, you could barely see yours. So I don't know how she's able
Well, you're
to do
stretching
that.
yours, Sarah, if I can be honest. You're stretching yours a little
Yeah.
bit. Having an ear piercing. Marty, you kind of asked about that. When you get a suprapubic tubes the same way, when you have an ear piercing, it stays open even when you don't have something in it. But Sarah, because you're keeping a catheter in there, you're kind of stretching that tissue out a little bit.
Right,
I think
right.
that's why you can probably see yours and you can't see the other one. The other thing too, Marty, when it comes to leaking, the bladder, if you see how Sarah's sitting there, her bladder's down low. And in order for urine to come up, it would have a really hard time fighting gravity and going up and getting out of her stoma. So
Right.
That's why it doesn't leak probably very often for her or anybody with a Mitrofanoff.
Gotcha. Okay. Anybody have any questions regarding the Mitrofanoff?
Roland here. Okay, so there's a surgery for women. Anything on the horizon for men?
You know, Medtronic is the one that's on top of that, Roland. They're the ones doing all of the, I don't know if you follow Medtronic, their neuromodulation team, they're working on bladder. They're kind of on top of bladder, everything. If you want to follow somebody, I would follow Medtronic. and see what they've got going on as far as electrical stimulation and control of those sphincters and the bladder. I'm not sure of what's on the horizon, but I know that they have a whole department for it, Roland, so it would be possible. And then just to clarify, Mitrofanoff, anybody can get a Mitrofanoff. It doesn't have, you don't have to be a female. We tend to do them on females more because it's harder for them to get to their anatomy. And so females tend to qualify for Mitrofanoff sooner because we want them to be independent and be able to catheterize when they're out and about. So you may hear about it in females, but men could, there's no reason why. You have an appendix. I mean, I don't know your history, but men could get one too.
Okay, didn't know.
Yeah.
Thank you.
Good question though. Yep. We didn't
Comments,
talk about
concerns?
that. Do you guys have any questions about having sex with a catheter in, huh?
Oh, well, there you go.
I'm
There might
surprised
be
it
some-
hasn't come up yet.
Yeah, you mean an indwelling catheter through the penis or through the?
Yeah, so you can still have sex with them. You just need to put a condom on over the catheter. Well, there's different things we can talk about, but no matter what you use to manage your bowel and bladder, I want you guys to have the healthy sex life that you want. So if you guys have questions, bring it up to your providers, bring it up to me. It's definitely not off. I used to be they called me the sex expert at Craig. It's something I'm very passionate about for you guys. If it's something that you want to talk about, we can talk about that. There's different ways to deal with that indwelling so that you guys can have a sex life that you guys want to have. Quiet
I have a
girl.
question. I have a quick
Hey,
question.
Yeah.
Yeah.
Curtis, you go.
So I use it's called a Vapro, so it's a bag catheter. Yeah,
Yep.
and so I can't remember what you're talking about, or the hydro.
It's hydrophilic.
Hydrophilic.
It's hydrophilic. Yep.
Yeah. Do they make a system like that where with a bag system with that type of tube?
With do they make a catheter with a bag?
Well, a catheter with a bag, but with I can't remember what you're talking about. A hydro.
So Vapro is hydrophilic. The catheter that you're using?
Yeah.
So you're using one of the best, I think, Vapro. It's got a bag attached and it's got the hydrophilic coating and it's got the sheath, right? Do you grab onto it? Yeah.
Oh, so that has the coating? Oh.
That's
Okay.
got the coating on it. Yep.
Oh, okay.
That's
I didn't
Hollister.
realize that.
Yeah, so you're using Hollister for both your bowel and bladder. And so
Yeah.
Vapro is Hollister's hydrophilic catheter. They're a great one.
Yeah.
Yep, that's a
Okay.
great one.
Okay. I didn't realize that. Well, I
Yeah,
guess that's,
good job,
I
Curtis.
guess I'll-
You're right
I
on
guess I'll
track.
stick with that.
Yep, stick with that if it's working.
I'm
Yep.
glad I asked.
All right, so with that being said, to wrap things up, is there anything else that anybody would like to say that needs to be said?
Yeah, I really
Yeah.
appreciate everybody joining us. Yeah, thanks.
Been a
DAC,
really good
for-
conversation.
The whole DAC WA for putting it on.
All right. Well, thank you, everyone. Have a good evening.
Yeah,
Great.
thank you, Amy.
Thanks all.
Yeah, thank you, Amy.